Welcome back to the deep dive. Today we are putting on our loops and scrubbing into one of the most technically demanding areas of the knee. We're moving past the main events, the ACL and PCL, and diving deep into the intricate network that holds the lateral side of the together. We're talking about the posterolateral corner, or the PLC.
That's right. And if the cruciates are the main struts supporting the building, the PLC is, well, it's more like the sophisticated, highly specialized suspension system that dictates how the vehicle handles sharp turns in uneven terrain.
I love that analogy.
Because if that suspension breaks, the whole ride gets sloppy, and you're just destined for mechanical failure somewhere else.
That really hits a nail on the head, because the complexity of the PLC is why it's so frequently misunderstood, or worse, just missed entirely.
Yeah.
It's the quiet gatekeeper. But when it fails, that knee instability is just debilitating.
Precisely. And for us, the mission today is to master the anatomical and surgical blueprints for this region. We have to elevate our index of suspicion for these sometimes occult injuries.
Right.
Because, as you know from the literature, Harner and colleagues highlighted this years ago, an associated PLC injury is a leading cause of residual instability. It's a direct predictor of primary reconstruction graft failure, whether you're fixing an ACL or a PCL.
So you're saying you put a new cruciate ligament into an unstable frame.
And that new ligament is doomed. It's just going to stretch out.
And that's the core problem we face in the acute setting, isn't it? It's almost never an isolated PLC tear.
Very rarely.
We know that only about, 25% of ligament injuries in this region are truly isolated. The rest are part of a multi-ligament complex.
Exactly. You fix the obvious tear, you miss the lateral instability.
And you get that persistent instability that just cripples the outcome.
It does. So before we can even talk about reconstruction, we have to talk about geography. You just can't navigate a surgical field this complex without a millimeter by millimeter understanding of the relationships. Let's start by pulling up the blueprint.
Okay, let's unpack this anatomy. It truly is a neighborhood packed with vital structures, all nestled so closely together. If we're going to be successful, we have to move past generalities and get, incredibly specific about attachments.
We must. And the cornerstone of the lateral complex is the Fibular Collateral Ligament, the FCL. It is the absolute primary static stabilizer against varus stress.
It's what keeps the knee from bowing outward.
That's its job.
And its attachments are not just near the epicondyle. They're a precise, non-isometric surgical GPS coordinate, thanks to those exhaustive dissection studies done by LaPrade and his team.
This is where surgical success begins. You have to nail the femoral attachment. It sits in a small, distinct, bony depression, specifically located 1.4 millimeters proximal and 3.1 millimeters posterior to the lateral epicondyle.
Wow.
So you think of the lateral epicondyle as your center point, and you're immediately moving up and back.
That precision sounds impossibly tight. What is the tolerance for error, practically speaking? If a less experienced surgeon misses that mark by even 2 or 3 millimeters, what's the consequence?
The consequence is immediate biomechanical failure, or at the very least, predictable stretching. If you place that graft too anteriorly or too distally, the graft won't function isometrically, meaning it'll either be too tight in flexion, causing stiffness, or, more commonly, it will stretch out in extension, leading to recurrent instability.
So that 1.4 by 3.1 measurement, that's the sweet spot.
It is the sweet spot for isometry. Getting that tunnel right means the difference between a functional knee and a chronic failure.
That context makes those numbers much more than just trivia. And distally, the attachment on the fibular head is 8.2 millimeters posterior to the anterior margin of the fibular head.
Yeah.
It's critical to remember that separation for the biceps tendon insertion.
Yes. And we also need to appreciate its dimensions. We're talking about a structure that averages nearly 70 millimeters in length, 69.6 millimeters to be exact, and has a substantial cross-section.
Right.
And that cross-section decreases slightly as it moves from the femur, where it's about 0.48 centimeters squared, down to the fibula, where it's 0.43.
And that reduction in diameter on the fibular side, is that significant?
I think it's a reminder that it's designed to function primarily as a static restraint, not a dynamic muscle tendon unit.
Okay, we've covered the FCL. Now, deep to that strut lies the dynamic stabilizing heart of the PLC, the popliteus complex. We often hear this referred to as the fifth ligament of the knee.
If the FCL is the heavy-duty strut, the popliteus tendon, the PLT, is the dynamic cable system. It courses deep to the FCL, originating on the posteromedial tibia, running obliquely, and inserting into a distinct sulcus on the lateral femoral condyle.
And this spatial relationship between the FCL and the PLT on the femur is what absolutely dictates our reconstruction tunnels.
It's non-negotiable for an anatomical reconstruction. We rely on the meticulous mapping that showed the PLT femoral insertion is always anterior to the FCL femoral attachment.
Always.
On average, there's a clear separation of 18.5 millimeters between those 2 points. So if your surgical plan doesn't account for those 2 distinct separated tunnels,
you're not recreating the native anatomy.
You're not. And the PLT itself is quite robust, measuring 0.59 centimeters squared at its insertion, actually slightly larger than the FCL itself.
So we have the FCL posterior, the PLT anterior, separated by nearly 2 centimeters. And connecting the popliteus complex back to the fibula, we get to the popliteofibular ligament, the PFL.
The PFL is arguably the structure that gives the PLC its true rotatory control. It's the dark horse. It originates from the musculotendinous junction of the popliteus and runs obliquely, inserting onto the posterior surface of the fibular styloid.
And it's not just one structure, right? It has those 2 divisions.
Exactly. It has anterior and posterior divisions, with the posterior division being the larger and more robust one at the fibular attachment. But what's really critical is its function.
Which is?
The PFL is a major static restraint to external rotation. When we discuss a dial test later, understanding the PFL's primary role in preventing the tibia from twisting externally at 30 degrees of flexion is absolutely key.
Moving beyond the primary ligaments, we have the supporting cast of dynamic structures and capsular thickenings. Let's talk surgical landmarks.
Sure, the lateral gastrocnemius tendon is often overlooked, but provides crucial orientation. Its attachment point is 13.8 millimeters posterior to the FCL femoral site.
Okay.
And critically, it's injured far less frequently than the FCL or PLT, making its insertion a reliable, visible anatomical signpost during a complex dissection.
And nestled right there, we sometimes find the fibella, that little bean sesamoid bone.
It's a fun little anatomical quirk, isn't it? Found in about 30% of people as bone, though a cartilaginous analog is present in 66%. And the fibella-fibular ligament extends from the fibular styloid to the fibella, reinforcing that posterior lateral capsule. This whole area is just a network of passive checks and balances.
Then there are the massive dynamic stabilizers, the biceps femoris tendon.
Its long and short heads are essential. When we look at the long head, it splits into 2 main arms near the fibular head. The direct arm, which inserts posterolaterally and is the functional component, and then the anterior arm.
And for us, surgically, the interval between those 2 arms, the direct and anterior, that's the critical access point to get deep to the SCL during a reconstruction.
It is. It's like finding the perfect parting of the curtain to get to the main stage.
The secret pathway.
It is the secret pathway, but as you navigate that pathway, you have to have the common peroneal nerve at the forefront of your mind. The long head of the biceps femoris is the key landmark. The nerve lies just slightly posterior to the biceps tendon, running superficially.
So any open approach to the PLC.
It necessitates extensive neurolysis and very gentle retraction of that nerve, often into an anterior sling, to prevent a devastating iatrogenic injury.
That nerve is why any PLC procedure takes twice as long and requires meticulous patience. If you're rushing, you're risking a foot drop.
Absolutely. Moving superficially, we hit the iliotibial band, or ITB, inserting at Gerdy's tubercle. We have to consider its capsuloosseous layer, which attaches posterior and proximal to the main insertion. It's a robust secondary stabilizer.
And finally, the capsular thickenings that have garnered so much interest over the last decade.
Yes, the anterolateral ligament, or AL. It's a lateral capsular thickening, important for coordinating rotatory stability. It originates posterior and proximal to the FCL attachment and courses down to the anterolateral tibia. It really works in concert with the ACL.
And the clinical signature of the ALL is the Seguin fracture, that small bony avulsion fragment off the lateral tibial plateau that you see on a plain film.
That finding is an absolute red flag. If you see a Seguin fracture, you know the AL has been avulsed, and you have to assume a significant lateral injury, usually combined with an ACL tear, because the force required to avulse that bone is immense.
Okay.
Understanding the anatomy here transitions directly into understanding the biomechanics of failure.
Okay, let's talk function. This is where we synthesize the anatomy into a working model, leveraging those foundational studies of Grude, Golohan, and others who precisely measured the contributions of these structures. The lateral knee is, well, it's a marvel of redundant engineering.
It is. The interaction is incredibly complex because a structure's primary role at 0 degrees of flexion might become a secondary role at 90 degrees. Let's start with the most straightforward force, varus stress. Pulling the knee open laterally.
The FCL is the undisputed champion here.
It's the primary restraint across all angles of flexion. The classic cutting studies showed that selectively sectioning the FCL resulted in a measurable increase in varus opening. That is its singular, most important job.
But if we lose the FCL, the secondary stabilizers immediately take on an undue burden. So which structures step up?
The system tries desperately to compensate. The popliteus tendon, the PLT, is a minor primary varus stabilizer, but once the FCL is gone, the secondary restraints activate powerfully, and the list is long.
Okay.
You've got the PFL, the entire ITB complex, the lateral gastroc tendon, the biceps heads, and critically, the cruciate ligaments themselves.
Right.
The cruciates only contribute significantly to varus resistance once the FCL is non-functional.
That explains why an isolated FCL tear can often lead to a feeling of instability. But the full-blown instability seen in grade 3 tears often involves concurrent damage to the ITB or other secondary restraints.
Exactly. The system is designed with safety margins. When you exhaust those secondary restraints, that's when you see symptomatic varus gapping on exam.
Now let's move to the complexity. External tibial rotation, the twist. This is the mechanism that most often defines the PLC injury in terms of function.
This is where the popliteus complex really shines. The FCL, PFL, and PLT are the primary restraints to external rotation. And biomechanically, this instability is most pronounced when the knee is partially bent, specifically between 30 and 40 degrees of flexion.
Why that specific angle? Why not 0 degrees or 90 degrees?
It's due to the configuration of the collateral ligaments and the bony geometry. At 30 degrees, the cruciates are more relaxed, and the collateral ligaments are relatively parallel, which allows that rotatory moment to be maximized.
The PFL has taught us there.
Exactly. At full extension, bony congruence and capsular tension limit rotation. And at 90 degrees, the PCL and ACL are highly engaged, limiting rotation significantly.
And this brings us back to that crucial connection. The PCL and PLC acting as reciprocal stabilizing partners.
This is one of the most critical takeaways for any orthopedic surgeon. The PLC structures are secondary stabilizers preventing posterior translation, which we'll get to shortly. But conversely, the PCL acts as a powerful secondary restraint against external rotation.
So if you have combined PCL and PLC injury, which is a far too common scenario after high-energy trauma like an MVA,
Right.
you've lost the primary static restraints for varus and external rotation, and you've lost the key secondary restraint for rotation, which is the PCL.
Precisely. Those knees are hyper unstable. They are exponentially more unstable under external rotation forces than a PCL isolated injury or a PLC isolated injury. The synergistic failure is catastrophic, which is why the dial test, when positive at both 30 and 90 degrees, is such a terrible prognostic sign.
Let's discuss tibial translation AP stability, starting with anterior translation. We know the ACL is the main restraint. How much does the PLC help the ACL?
The PLC structures are crucial secondary stabilizers to the ACL, particularly in the first 40 degrees of flexion. In an ACL-deficient knee, the PLC acts as an important braking system, trying to prevent that tibia from sliding too far forward.
But it's not its main job.
No, it's not. But when you lose both the ACL and the PLC, you lose the primary brake and a strong secondary brake, leading to that classic sloppy knee.
Now, posterior translation, the push. The PCL is the primary stabilizer, but you mentioned the PLC structures play a significant primary role here too. That kind of runs counter to how many people conceptualize the PLC.
It's a crucial distinction, and it's based on the work by Gallahan. The PLC structures, especially the PLT, exert a significant primary force in preventing posterior translation. This is most notable in full extension and at lower flexion angles, where the PLT is under the most tension because of its oblique course.
So the PLT is helping the PCL keep the tibia from shifting back, especially when the knee is straight.
Exactly. And in a PCL-deficient knee, the contribution of the PLT complex increases markedly. The PLT is trying to keep the back door of the knee shut when the main hinge, the PCL, is broken.
Wow.
Failure to reconstruct the PLT in a PCL-PLC combined injury is simply unacceptable because you leave the knee with no active check against posterior sag and extension.
Finally, internal tibial rotation, the twist inward.
The ACL is primary here at low flexion, and the ALL, the anterolateral ligament, works synergistically with the ACL, providing increasing resistance as the knee flexes up toward 90 degrees. The PLC structures, the FCL and PLT, are secondary restraints here, primarily relevant when the ACL is deficient, trying to compensate for the loss of the main internal rotation brake.
So in summary, the PLC is the varus protector and the external rotation cop. But it also serves as a critical secondary check for anterior translation and a primary check for posterior translation and extension. It's a system built on interlocking duties.
It's a complex pulley and cable system. If you take out the main cable, say, the PCL, you immediately overstress the FCL and the PLT in their role as secondary stabilizers for rotation and primary stabilizers for translation. That's why we always say if you have an ACL or PCL injury, you must rule out the PLC because the surgical success of the major ligament relies entirely on the stability of this complex suspension.
Moving from the lab bench to the clinic, how do we reliably diagnose these injuries? We established that they are often hiding in plain sight.
Diagnosis requires clinical suspicion and a systematic approach. The history is your first major clue. The mechanism of injury is often telling, either a direct blow to the medial knee forcing the knee into varus or a non-contact hyperextension injury.
And the high-energy nature is critical to note. We often think of these as sports injuries, but you noted only about 40% are sports-related.
That's right. Motor vehicle accidents, industrial accidents, falls from height. These account for a massive portion. These are high-velocity injuries that generate tremendous rotational and varus forces.
The symptoms often sound generic: pain, swelling, instability. What are the specific red flags that make us think posterolateral corner?
The key patient complaint is a subjective side-to-side instability, particularly when they transition toward full extension. They feel the knee giving way on uneven ground. But the most specific and observable finding, if they can bear weight, is the varus thrust gait, that visible momentary bowing outward of the knee joint during the stance phase, when the femur shifts relative to the tibia. That is a pathognomonic sign of a failed lateral restraint system.
And before we even touch the knee, the first step has to be a detailed neurovascular exam.
Mandatory. I cannot stress this enough. Up to 1/3 of PLC injuries are associated with a common peroneal nerve injury. That's an alarming rate.
That is high.
You must perform strength grading for angle dorsiflexion and plantar flexion and meticulously check sensation, particularly the web space between the first and second toes for the deep peroneal nerve and the lateral calf for the superficial peroneal nerve. Foot drop or paresthesias are not complications. They are often part of the presentation, and they change your surgical timeline and urgency immediately.
Okay, let's get hands-on with the physical exam. The gold standard for static laxity, the varus stress test.
This is the litmus test for lateral gapping. It has to be performed meticulously, once at 0 degrees, full extension, and again at 30 degrees of flexion. And you always have to stabilize the femur and apply a gentle varus force to the tibia.
And if you have gapping at 30 degrees?
That's an FCL injury, potentially involving secondary restraints.
But the marker for true devastating instability is the 0-degree gapping.
Exactly. If gapping persists at full extension, you must assume a combined injury. You have lost the FCL, the PLC complex, and a major cruciate ligament, usually the PCL or ACL, because the full capsule and cruciates must be intact to prevent gapping at 0 degrees. The degree of gapping you measure is objective data we'll use for surgical correlation.
Next up, the dial test, measuring the twist.
The dial test is the key to rotatory instability. We measure the external rotation difference between the injured and uninjured knee at 2 flexion angles, 30 and 90 degrees. An increase in external rotation of greater than 10 degrees compared to the contralateral side is diagnostic for a PLC injury.
And the interpretation of the 30-degree versus 90-degree difference is critical for identifying combined instability.
It is. If the external rotation is positive at 30 degrees, but significantly more positive at 90 degrees, that suggests a combined PLC and PCL injury.
Why is that?
Because the PCL acts as the restraint at 90 degrees. If the rotation dramatically increases at that deep reflection angle, you know the PCL is gone. If the rotation is restricted at 90 degrees but positive at 30, it suggests an isolated PLC injury.
That distinction is conceptually challenging, but absolutely vital for surgical planning. But I recall the literature cautioned us about relying too heavily on the dial test for subtle injuries.
That's the nuance we have to recognize. Studies like those by Bay and others have shown that the dial test may not be sensitive enough to detect isolated 1 or 2 ligament PLC injuries. It often requires 3 or more structures, the FCL, PFL, and PLT, to be sectioned before the test reliably turns positive.
So a negative dial test does not rule out a grade 2 FCL tear.
It absolutely does not.
We also have the external rotation recurvatum test.
Right. You lift the leg by the big toe. A positive test shows increased hyperextension or recurvatum compared to the other side. While the sensitivity varies widely in the literature, a positive result is highly predictive, as LaPrade noted, of a combined ACL-PLC injury. It shows multiplanar instability.
And the reverse pivot shift.
This test checks for the reduction of the posteriorly subluxated lateral tibial plateau around 35 to 40 degrees of flexion. And while we use it, its reliability is questionable. It has a reported predictive value of 68% for PLC injuries, but can be positive in up to 35% of normal lax knees.
So it's more of a confirmatory test.
Exactly. It's best used as confirmatory evidence in the context of a positive various stress test.
Let's move to imaging. Plain radiographs are the starting point.
Acutely, they are often normal, but we are looking for those classic avulsion fractures, the bony signatures of ligamentous failure.
Look the second.
The second fracture signals all-L avulsion, and the arcuate sign, an avulsion fracture of the fibular head, strongly suggests avulsion of the PFL or biceps insertions. These demand immediate attention, and crucially, for chronic instability, the mandatory view is the standing long leg AP alignment radiograph. Without this, you risk catastrophic graft failure later.
And the objective measurement we rely on is the stress radiograph.
Absolutely. This is the gold standard for correlating clinical laxity with objective, quantifiable gapping. It is highly reliable and dictates the magnitude of injury. Laprade's cadaveric work established the benchmarks. 2.7 millimeters of increased gapping suggests isolated FCL sectioning, while 4.0 millimeters or more indicates sectioning of the entire PLC complex.
And that data informs our surgical decision-making.
Yes, and allows us to predict the number of grafts needed.
MRI is still essential for mapping the soft tissue damage.
MRI is critical in the acute setting. It boasts high sensitivity and specificity, over 90% for the FCL, ITB, and biceps tendon injuries. It tells us where the tear is, avulsion off the bone, or an intrasubstance tear.
There are limitations.
There are. You have to be aware that the sensitivity and specificity for the popliteofibular ligament, the PFL, are noticeably lower, sometimes dipping down to the mid-60% range. So if the clinical exam is highly positive, don't let a marginally negative PFL reading on the MRI dissuade you from exploration.
And finally, diagnostic arthroscopy, the ultimate visualization tool.
We use arthroscopy not just to look for concomitant intra-articular injuries, which are frequent. ACL tears occur in 63% of grade 3 PLC injuries, but to assess the stability dynamically. The key arthroscopic sign is the posterolateral drive-through sign.
What's that?
This is when you can pass the arthroscope easily between the lateral femoral condyle and the popliteus tendon. It indicates pathological lateral capsular laxity. Seeing that laxity confirms the need for reconstruction. So we transition now to intervention. And the consensus is clear. Grade 3 injuries, the complete tears involving 3 or more structures, almost always mandate surgical intervention because the risk of symptomatic chronic instability is just too high otherwise.
For the minor league 3 and 2 injuries, we can manage non-operatively.
Yes. We use a knee immobilizer or a hinged brace locked in full extension for 3 to 6 weeks to allow for soft tissue healing in a protected position. We allow full weight bearing, but we are aggressive about starting prone flexion exercises immediately to prevent arthrofibrosis, which is a significant risk in any immobilized knee.
And return to play.
Only permitted once stability is objectively comparable to the uninjured side.
But for grade 3 tiers, especially combined injuries, concurrent repair or reconstruction is mandatory. There is no debate there.
Zero debate. When fixing a concurrent ACL or PCL injury, you must address the PLC instability simultaneously. If you neglect the PLC, you leave the primary cruciate graft exposed to biomechanical failure. The knee remains hypermobile, and that new graft will just stretch and fail.
Let's hit the crucial topic, repair versus reconstruction. The history of primary repair in the PLC is, frankly, pretty poor.
It is. Historically, primary repair of intrasubstance, FCL, and PLT tears has been universally unsuccessful and is generally avoided today. Now, while we can successfully repair avulsed structures pulled cleanly off the bone using recession techniques, the evidence strongly supports reconstruction.
That standard at all prospective cohort study was a real eye-opener in the early 2000s.
It provided objective data. Repair was definitively inferior to reconstruction. Reconstruction had a manageable 9% failure rate, compared to a disastrous 37% failure rate for primary repair. The PLC complex, when fully torn, requires structural augmentation, not just simple stitching.
So if it's an acute avulsion off the femoral epicondyle, maybe you can attempt a repair. But if it's an intrasubstance tear, we are moving straight to reconstruction.
Absolutely. And we're moving past non-anatomic reconstruction techniques like the old Clancy biceps tenodesis or the standard modified two-tailed technique, which involved non-anatomical placement and tensioning. We now adhere to the principle of anatomic reconstruction.
Which brings us to the preferred anatomic reconstruction popularized by Laprade. Let's start with the isolated FCL reconstruction using a semitendinosus autograft. Walk us through the key technical steps.
First and foremost, safety. This begins with extensive neurolysis and retraction of the common peroneal nerve. You identify the nerve as it wraps around the fibular neck, you free it up, and you gently retract it, often using a vessel loop or a Penrose drain to protect it throughout the case.
Once the nerve is safe, tunnel placement is paramount.
The femoral tunnel is the most critical step. We use those GPS coordinates, 1.4 millimeters proximal and 3.1 millimeters posterior to the lateral femoral epicondyle. We use a guide pin, often drilled 25 millimeters deep, and ream it to 6 millimeter. And you must palpate the tunnel margins to ensure you haven't perforated the posterior cortex.
Then the fibular side.
A guide pin is placed from the FCL's native fibulae attachment site, that 8.2 millimeter point, and exits along the posteromedial downslope of the fibular head. We want to avoid compromising the PFL insertion if it's still intact. The semitendinosus graft is then passed deep to the ITB, threaded through the fibular tunnel, and recessed into the femoral tunnel.
Now for the critical step, tensioning. What is the magic angle and force?
The FCL graft is tensioned at a very specific angle, 20 degrees of knee flexion.
20 degrees.
While tensioning, a gentle valgus force is applied to the knee to ensure the lateral compartment is tightened and varus gapping is eliminated. This position ensures the graft is isometric across the range of motion. We use a bioabsorbable interference screw for fixation on the femoral side.
And if the bone quality on the fibular side is poor, which can happen with chronic injuries.
If the fibular fixation feels tenuous, we have the option of continuing the free end of the graft around the fibular head for extracortical fixation. It provides a belt and suspenders approach. This technique, which was validated by Kubes et al., has proven to restore varus and rotational stability to near normal levels for isolated FCL tears.
Now, let's tackle the full meal deal. The combined PLC and FCL anatomic reconstruction, the two-graft technique. This is what's required for most grade 3 acute injuries.
This is the technically demanding peak of PLC surgery, reconstructing the FCL, PLT, and PFL anatomically. We typically use a split Achilles allograft with 2 bone blocks, which gives us 2 strong integrated segments to fixate simultaneously at their femoral origins.
So this means we need 2 femoral tunnels, separated by that 18.5 millimeters.
Exactly. 2 separate eyelet pins are placed anatomically for the PLT and FCL insertions, the PLT pin anterior, the FCL pin posterior. We ream 2 9-millimeter tunnels, 25 millimeters deep. Next, we need the tibial tunnel for the popliteus complex reconstruction.
And that tunnel starts anteriorly on the tibia.
Yes, from the flat spot, that area between the tibial tubercle and Gerdy's tubercle, and is aimed posteriorly toward the popliteal sulcus. Again, with meticulous neurovascular protection, the tunnel is reamed to 9 millimeters.
And finally, the fibular tunnel.
1 tunnel is drilled connecting the FCL and PFL insertions. Now, the complex sequencing and tensioning protocol is what sets this procedure apart. First, the FCL graft is passed through the fibular tunnel, routed deep to the ITB, and fixed in its femoral tunnel.
And tensioned at 20 degrees with valgus force, just like the isolated technique.
Correct. But here's the difference. The tail of that FCL graft is continued to the posterior tibial aperture, where it forms the PFL component. Then, the separate PLT graft is fixed in its femoral tunnel. Both the PFL graft tail and the PLT graft are combined and passed anteriorly through the tibial tunnel.
So all the grafts converge in that one tibial tunnel. And what's the tensioning position for this complex?
This final construct, the combined PLT and PFL grafts, is fixed with an interference screw at a different critical position. 60 degrees of flexion while applying an anterior force to the tibia.
60 degrees.
This specific tensioning ensures maximal stability against posterior translation and external rotation in midflexion. McCarthy and others validated the biomechanical necessity of the PFL reconstruction through that specific tibial tunnel path to restore normal stability. This 2-graft, 4-tunnel technique restores stability to near normal levels across all planes.
Acute injuries are demanding, but chronic injuries, those presenting 3 months or more after the initial trauma, introduce a compounding factor that can doom even the most perfectly executed reconstruction.
The game changes completely with chronic instability. That confounding factor is varus malalignment. The original injury, combined with walking on an unstable lateral side, often leads to stretching of the medial structures and a chronic varus thrust.
And we define varus malalignment objectively, using the standing long leg AP alignment radiograph.
Absolutely mandatory. Varus malalignment is defined as when the mechanical axis of the limb falls medial to the tip of the medial tibial spine. If that axis is medial, the load is perpetually concentrated on the medial compartment, opening up the lateral side.
And the reconstructed ligaments will simply not survive that chronic load.
They cannot tolerate it. You'll see early graft stretching and symptomatic failure within months. Therefore, correcting that malalignment with an osteotomy must be performed either prior to or concurrently with the ligament reconstruction. This is a foundational principle of chronic PLC management that LaPrade and others have established. You must fix the foundation before you fix the walls.
And your preferred method is the proximal tibial medial opening wedge osteotomy, or PTMOWO, Y opening wedge.
Biomechanically, the opening wedge has been shown to be superior to a lateral closing wedge. It decreases both the chronic varus motion and the external rotation laxity. Furthermore, PTMOWO gives us surgical control over the posterior tibial slope, which is crucial in multi-ligament injured knees.
So we can fine-tune the biomechanics.
Precisely. If the knee is PCL deficient, we might increase the slope slightly to drive the tibia anteriorly. If the knee is ACL deficient or has an established flexion contracture, we can slightly decrease the slope. It's a versatile tool for overall limb realignment.
Let's detail the technical steps of the PTMOWO, focusing on avoiding catastrophe.
We begin with the alignment pins. We position the guide pins parallel to the joint line in the coronal plane, approximating our desired tibial slope in the sagittal plane. Using an oscillating saw, we make the cut through the medial cortex, followed by osteotomes, working meticulously across the tibia. The key is maintaining a careful, intact hinge approximately 1 centimeter along the proximal lateral tibia. We stop just short of breaching the lateral cortex to maintain stability.
The temptation to complete the cut must be resisted.
Absolutely. Then, using a specialized spreader, we gently distract the medial cortex to achieve the required opening measured based on our preoperative planning and hold it for several minutes to allow stress relaxation. We then fix the open wedge with a specialized plate and screws and pack the defect with autologous or allograft bone graft to promote fusion and support the opening.
The postoperative regimen here is exceptionally rigid, I imagine.
It has to be. The patient is placed in an immobilizer for up to 8 weeks. Weight bearing is strictly restricted until 8 weeks post-op to allow for reliable bone healing across the osteotomy site. And we have to be rigorous about preoperative counseling regarding lifestyle factors. No tobacco use allowed, given the high risk of non-union with impaired healing.
And often this is the first stage of a 2-stage process.
Yes. If significant instability persists after the correction, the secondary ligament reconstruction is performed later, typically 6 to 9 months after the osteotomy, once there is clear radiographic evidence of complete healing and consolidation of the osteotomy site. We want to ensure the foundation is rock solid before laying the new ligaments.
And the results of this approach are very encouraging. I remember the Arthur study on this.
The outcomes are fascinating. Arthur et al. Found that 38% of patients with chronic PLC deficiency who underwent the corrective osteotomy had such sufficient improvement in stability and alignment that they did not require a subsequent ligament reconstruction.
Wow, 38%.
Fixing the axis alone can restore enough inherent stability to the knee to make reconstruction unnecessary. That speaks volumes about the importance of mechanical axis correction.
Let's finish with the overall outcomes of anatomic reconstruction.
Right.
Are we truly restoring stability?
Objectively, yes. The results of the anatomic techniques are robust. We see better results in acute settings when combined with concurrent cruciate repair construction, a 9% failure rate compared to the disastrous 38% failure rate for staged repair. For isolated FCL reconstruction, patient outcomes measured by scores like the modified Cincinnati score improved dramatically, often jumping from pre-op scores in the 20s to post-op scores nearing 90.
And the objective stability, measuring that varus gapping on stress films.
Kieslin and LaPrade demonstrated that we are restoring near-normal static conditions. Preoperatively, patients typically demonstrated 6.2 millimeters of varus gapping on stress radiographs. Post-anatomic reconstruction, that number dropped dramatically to a near-normal 0.1 millimeters. The stability is reproducible and predictable when the anatomical principles are strictly followed.
Finally, we have to revisit complications. The nerve is the most obvious risk.
It is the ever-present threat. We noted up to 30% of patients present with a peroneal nerve injury, and despite meticulous neurolysis, there is always an inherent iatrogenic risk during the procedure due to the required retraction and proximity of the nerve. We manage this risk through careful exposure and postoperative monitoring. And DVT. We also routinely institute DVT prophylaxis, typically with daily enteric-coated aspirin 325 milligrams, given the necessary post-op immobilization and surgical exposure.
And the risk of graft failure itself.
Minimized significantly by 2 factors. adherence to the precise anatomical tunnel placement, and the absolute preemptive correction of any underlying varus malalignment. Skip either of those steps and you invite failure.
This has been an incredibly detailed and valuable journey. We've covered everything from the microscopic 1.4 millimeter measurement to the staged surgical correction involving osteotomies. The key learning points are crystal clear. The FCL is primary for varus, the PFL is key for external rotation, and in chronic cases, if the axis is off, the ligaments will fail.
Absolutely. PLC injuries demand precision and comprehensive thinking. They're not a simple entity, but a complex interaction of static and dynamic structures. The data from Giesland and Lepred confirm that while technically demanding, the anatomic reconstruction approach yields robust and objectively stable knees. If you are going to address the lateral knee, you must approach it with the precision of a watchmaker and the caution of a highway engineer.
Fantastic. Now, as we wrap up this deep dive, I'm left with this final thought for you, the learner. We spent a lot of time discussing how the dial test often misses those subtle 1 or 2 ligament PLC injuries, which we know can lead to chronic instability if they're ignored.
Correct. The threshold for the clinical exam is often too high.
So, given how absolutely critical the common peroneal nerve is in this area, and given the complexity of navigating this field surgically, how long until we stop relying on the physical exam for the subtle tears and instead rely solely on the combination of high-resolution stress radiographs for objective gapping, combined with AI-assisted MRI interpretation to precisely map the damage, including those low-sensitivity PFL tears, before the patient ever gets to the operating room? Relying on high-tech diagnostic precision rather than a subjective physical exam seems to be the frontier we must fully embrace to catch these injuries earlier.
That's a powerful thought. If we can improve detection fidelity for those grade 1 and 2 tiers and intervene earlier or guide targeted non-operative management, we dramatically reduce the number of patients developing chronic, complex varus malalignment down the road. The true long game is prevention through early, precise diagnosis.
Agreed. Thank you for joining us for this deep dive into the posterolateral corner. We'll see you next time.